Disclosures for this and all episodes in this series can be found on the podcast series destination page located on education.webmd.com. The following presentation is copyrighted by WebMD Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of WebMD Education. The following podcast is supported by an independent educational grant from Bayer.
Hi, and welcome back to our podcast on preventive cardiology and preventing cardiovascular disease, where the theme is know your risk and act early. My name is Michael Blaha from the Johns Hopkins Ciccarone Center for the Prevention of Cardiovascular Disease, and hopefully you joined us for episode 1 of our series, which was on primordial prevention, talking about how cardiovascular disease doesn't just happen overnight. It's a chain reaction that starts earlier than you think. And now we'll get on to episode 2, where we talk about a risk assessment, specifically cracking the code with coronary artery calcium. And it's my great pleasure to welcome Dr. Fatima Rodriguez with me today. She's the Vice Chair of Clinical Research for the Department of Medicine and the Section Chief of Preventive Cardiology at Stanford School of Medicine. Thank you for joining us, Dr. Rodriguez.
Thank you so much, Dr. Blaha. And I may say that you have done a lot of the seminal research on coronary artery calcium. And it's really great, I'm sure, for you to see all of the body of work that you've done on the research side really translating to how we care for our patients today.
Super excited. Also, your research and see it cited in our guidelines, which I'm sure we'll talk about. So, yeah, the theme today is knowing your risk. We talked in the first episode about how it's hard with just risk factors alone to know what your risk is, and therefore it's hard to know how to proceed with preventing heart disease. So we're going to talk today about a test, which is a non-contrast cardiac-gated CT scan called the coronary artery calcium score. And this is something, of course, we use in practice to determine risk, and sometimes we'll use it to guide our treatment decisions. So let me start there, Dr. Rodriguez. Let's just start from the basics. What is a calcium score, and what is it actually measuring?
So, a calcium score, as you mentioned, is a quick non invasive CT scan. There's no contrast, and it is gated to the beating of the heart for a gated scan. And it detects the amount of calcified plaque in the arteries of the heart. And again, it's a fairly simple measurement, and it measures the density of calcium in the arteries. And it's really a marker of existing atherosclerotic disease. Very commonly used just to help us decide if we're going to treat patients. And I know we're going to talk a little bit more about that. And one of the important factors for CAC testing is that oftentimes patients do have to have an out of pocket cost. It could be minimal, but that sometimes limits the accessibility of this test.
Yeah, that's a good point. So, okay, great. We're measuring calcium, and calcium means atherosclerosis. So, tell us about the score, right? So, you can get scores that run from 0 to actually really, really high, of course. So, translate that score for us. How should we interpret what a score means?
So, whenever you order a CAC scan, you will end up getting a report that tells you the amount of calcified plaque and something called Agatston units by each artery, the left main, and so forth. And you get a sum. And what you and others have really shown definitively in a lot of robust epidemiological data is that this number, this Agatston score, correlates very much in a stepwise fashion to risk. If your score is 0, that is a very powerful de risking element. And often that's why patients get a calcium scan. But if that score goes up to very high levels, really above 300 Agatston units, it really is almost equivalent to that of established coronary disease. And that really helps us decide how intensive do we need to be in our therapies, particularly LDL lowering, but also aspirin and other therapies.
Yeah, great point. So, yeah, we think about 0 obviously being no detectable plaque, 1 to 100 being mild, like you said, 100 to 300 being moderate, above 300, sometimes even above 1,000, we'll see, can be quite high or even extensive coronary calcium. There's also, right, on those reports, sometimes it'll talk about, or it should talk about the percentile, right? The percentile score. So, Dr. Rodriguez, tell us what the percentile means.
I really love that question because I just saw a patient in clinic, very young, under 40, with a calcium score of 15 Agatston units. By what we just said, that's a fairly low score. That's mild plaque. But should a 36-year-old have a score of 15? No. And, she was above the 99th percentile for her age and sex. So it has to be interpreted in context. I often find that the absolute number is helpful to have the discussions, but it is helpful to see where you are for your age. and no amount of calcium or plaque really should be there in younger individuals.
Yes, that's such a great point. The absolute score basically tells you how much plaque you have, but the percentile score gives you your result relative to your age and sex matched peers. So this is so important, as you mentioned, particularly for young ages, where any plaque or certainly an elevated score is extremely abnormal. That's one of the things about we talk about in this podcast is knowing your risk early and starting early. So sometimes, obviously, detection of plaque at an early age can cause us to treat risk much more aggressively at a young age. And I think that's one of the themes of our new 2026 ACC/AHA dyslipidemia guidelines, which indeed are cholesterol guidelines, but they talk about risk assessment and actually feature the calcium score. The calcium score has actually gotten a higher level of recommendation than it ever has before. So, Dr. Rodriguez, tell us about that. Where is calcium score recommended in the new guidelines?
We were all so happy to see this change in the guidelines. A calcium score has always been used to help us in areas where statin decisions may be uncertain. So, those at intermediate risk or even low risk, really to have those decisions around should we start therapy. The new guidelines say that in the borderline or intermediate risk individuals, and this is calculated by the PREVENT score, so it's a new risk equation. Actually, you should do because it's a class 1 indication, obtaining a calcium score to help us decide, do I really need a statin for this patient, and engage in shared decision making around those decisions.
Yeah, great point. So calcium scoring now has, like you said, a class 1 recommendation for guiding lipid lowering therapy. But interestingly, also seems to have a role in our new guidelines for guiding intensification of lipid lowering therapy too. So not just the initiation, but the intensification. And the reason why I say that is in the guidelines, right? It gives some LDL goals according to the calcium score, right? So the idea, I guess, is the higher the risk, the lower the LDL. So Dr. Rodriguez, tell us a little bit about that. If you could tell us the principle here behind why calcium score helps you set your LDL goal, and then what some of those LDL goals should be for the higher risk patients and how that compares even to a secondary prevention patient.
Absolutely. And I really like this more detailed around what to do with a calcium number across the guidelines. So basically, the guidelines say that any amount of calcium, a score above 0, like my patient, you should really start targeting LDLs under 100. I think for all of us in preventive cardiology, that still seems too high, I will say. But of course, this is based on data that exists, and that's where these guidelines are obtaining these numbers. Again, calcium scores over 100, targeting LDLs under 70. But really, for us in the preventive cardiology community, and I think it's suggested in the guidelines, lowering it even further under 55 when you're getting calcium scores over 300, over 1,000 to match the level of intensity that is recommended for a secondary prevention population.
Yeah, that's such an important point. And really, one of our themes of the podcast is this risk continuum. And this is this overlap for high risk primary prevention patients based on their elevated subclinical atherosclerosis by imaging, here, the calcium score, with lower risk secondary prevention patients. So we can have patients that are in primary prevention with high calcium scores as high a risk as our secondary prevention patients who maybe have been stabilized after their coronary syndrome, for example. Now, we've talked a lot about ordering a coronary calcium score, right? A dedicated scan to look for calcified atherosclerosis in the arteries to guide our treatment. But of course, something like 10 to 20 fold more chest CTs are ordered compared to calcium scores every year, right? It's not uncommon to open up your patient's chart and they've had a chest CT because they had pneumonia or they had another problem of any sort, and they've had a chest CT. And lo and behold, increasingly, hopefully, our radiology colleagues are noticing that you can see coronary artery calcification even on those regular non-gated chest CTs. And then you've been the pioneer in this field of talking about how we can leverage that information too, because, hey, it's free information. The patient's already had the image, and it's actually sitting in the medical record, perhaps being unused. So tell us about this idea of opportunistic or incidental detection of calcium on a non-gated chest CT.
Yes, this is such an important topic and something that I'm very passionate about. And it really started with the clinical observation that, again, although I love calcium scans, they're invaluable in my practice, even the out of pocket cost, which is fairly high at my institution, is just not at reach for most individuals. And it requires you to be seeking preventive care, right, and have the scan ordered. But many patients have all sorts of imaging for other reasons, like you said, lung nodules, pneumonias, and that's information that's already sitting there. So what our group at Stanford has done is work with a computer scientist to develop an algorithm that can quantify the amount of plaque incidentally in these non-gated, non-specialized CT scans. But again, even our guidelines suggest that you don't need an AI algorithm to quantify the plaque. Just noting the presence of plaque, is it none? Is it mild? Is it moderate? Is it severe? Again, correlates in this graded relationship to risk. So we can use that information to guide statin decisions, treatment decisions, and show patients, visually show the patient, you have plaque in the arteries of your heart. There is something we can do to reduce this risk.
Yeah, great. And this is recognized based on your work and others that in the guidelines, right? This is a class one recommendation on these chest CTs to make note of this coronary calcification and act on it. And there's even recommendations to go ahead and initiate lipid lowering therapy based on these results. So this is great. But give us our listeners a sense here. Is this hard to do? Is it hard to look at one of these chest CTs and see coronary calcium?
I think it's hard to do when there's a lower amount of calcium, but of course these are not gated CT, so there's a lot of artifact. So I would say if they don't see calcium, that's not 100% ruling out calcium, but at least at the moderate and severe range, I think most of us can see it, and again, it's just a big chunk of plaque, even though there's a little bit of artifact from just not being gated to the beating of the heart. But it's very valuable, and I don't think an individual needs to obtain a gated chest CT just to calculate a number. I think that's sufficient information to start statins and lower the LDL cholesterol.
Even a primary care doctor, right, who doesn't routinely think about imaging can open up a chest CT and just browse the scan to see if there's calcium. But ideally, right, our radiology colleagues would make it a habit.
Yeah,
In fact, there's a
and
class
I'll
one
make a
recommendation, right?
point that it is recommended actually in the radiology
Yeah.
guidelines that if you notice the presence of plaque, you should mention it and you should quantify it in qualitative terms at least to help people make decisions. And in our work, when we notified patients of the presence of incidental calcium, we actually noted that about 90% of the radiology reports contained mention of atherosclerosis. Now, the question is this brought up to the impression where patients can use it in a way that's actionable? So we need to do a lot more work there, not just identifying it, but helping people make decisions based on that plaque.
Yeah, great point. Yeah, you guys showed very impressively when you notify someone, right, of their previously elevated calcium score from a non-gated CT that they didn't know about, they're much likely to go on preventative therapy, right, which we know saves lives and prevents cardiovascular disease. So that was a really monumental finding for the field. So in this idea of talking about cardiac CT, I do want to bring up the question that comes up a lot, which is the calcium score is great, but what about CT angiography? Where does that fit in? Let's talk about specifically first the asymptomatic patient, then of course the symptomatic patient.
There's no questions that CT angiography provides additional information beyond the presence of calcified plaque. And they provide information around soft plaque. Again, sometimes it requires you to look for it in more detail, and there are AI algorithms that are being developed that can help us quantify that plaque. There's been several studies that show that maybe 5 to 15% of patients who have a calcium score of 0 may have some soft plaque. But in general, for the individual patients, especially at a population level, CAC provides a significant discriminatory power to help you guide decisions. And there's no current indication for a CT angiogram for asymptomatic patients in primary prevention. I'll make the distinction that in secondary prevention, not even secondary prevention, but just the symptomatic patients with chest pain, and that's shown in our chest pain guidelines, CT angiography is an invaluable test. So if you do have a CT angiogram for some other reason, it is very valuable to not just say, is there stenosis? Is there something that we do? But is there plaque? Because I often see people say the CT scan was fine. Again, we should look to make sure there's not plaque that we can help manage with medications.
Yeah, that's such a great point. So I want to circle back to discussing these results with patients. I think it takes a little skill, right, and a little time to translate these results to patients. So you brought up a great case that you had a young patient below the age of 40, score of 15, was a woman, very high percentile. How did you discuss that with the patient? Could you walk us through that?
Sure. So in this patient, again, she was very resistant to start a lipid lowering therapy, even though her LDL was quite high, not quite familiar hypercholesterolemia level, but in the 160s or so, just did not want to start therapy. So another cardiologist ordered a calcium scan and again came at 15. The first thing I do is I always show the pictures. And again, with a low amount of plaque, it's sometimes helpful, but you can see a speck of coronary calcium in the arteries. And I said, this is your artery. This is plaque. We see plaque. This is real. This has shifted from a risk factor. This has shifted from a percentile on a risk equation to there are plaque in your arteries. But there's always a but. We can really do something to reduce your risk back to the levels that you should have for your age. And that almost always the patients are willing to start a medication, lower LDL goals, and not just the LDL, but also change their lifestyles. And I've seen that over and over again. It really adds a sense of urgency. And again, the framing, we want them to change behavior, but at the same time, reduce anxiety and say, this is not something that you need to have another test for, which is always the next question. Should I get a CT angiogram? Should I get a stress test? And the answer is no. If you're asymptomatic, let's control your risk factors, improve your lifestyle. And that's all we need to do.
That is such an important point. This comes up a lot. We do need to spend time talking patients away from follow-up testing when it's not indicated. Now, let me have one more follow-up question before we close out. So what if the patient says, well, my score is only 15. I read online that's not very much. Now, this is a unique patient, but how would you answer that question?
Again, this is where the percentile is very helpful. So I said, for your age and your sex, this is in the 99th percentile. This is not expected. And this means that even though you're very young, you have had plaque that has had time to calcify. So we say this exposure of this high LDL over a very short amount of time has already deposited in your arteries. And it always almost motivates action, but it does require a little bit of extra time and motivation to say, what does it mean when you have this number? I will say the flip side is also and this is more on the clinician side, if the calcium score is 0, and I had a patient like that today, it allows thoughtful deferral, again, in the right context, if you don't have any other high risk features. And this was, again, in the guidelines, as I believe is a class 2A. If you don't have diabetes, familial hypercholesterolemia, it is reasonable to defer treatment.
Yeah, that's such a great point. That is one of the values of the calcium score. It both finds lower risk patients than we thought. It also finds higher risk patients than we thought. It finds patient at high near-term risk, or like your patient, high long-term lifetime risk. It can be extremely valuable, once again, for the theme of this series, which is know your risk and, when appropriate, act early. So I want to say thank you, Dr. Rodriguez, so much for coming on. This was great. Once again, I want to thank you so much for joining this podcast on preventive cardiology and on how we can use, in this case, imaging tests to know our risk, guide our therapies, and of course, improve cardiovascular health. So with that, I'll say thank you, Dr. Rodriguez.
Thank you, Dr. Blaha.